Hello, we're here at the American Academy of Ophthalmology meeting, and I have with me Dr. Kalabari, who's a general ophthalmologist from Charlotte, North Carolina. It's great to be back at the American Academy of Ophthalmology and see so many people here from around the country and see people rekindling relationships with people they haven't seen in 2 years. But we're here to talk about electrophysiology and its practice in the general office. Now, many of you, when you went to medical school, probably had a short course in electrophysiology and saw this big machine and all these things touching the eyes and dilations and so forth, and may not have seen it much since then. It has tremendously changed with a handheld device that is able to be used in a lane, very portable and capable of performing all ERG testing. And so we're delighted that Dr. Kalabari, affectionately known as Dr. K, will join us today. And I'd like to get it off by asking Dr. Kalabari, tell us about your practice and what type of patients that you see in your practice, doctor.
Sure. First of all, Jim, thank you for having me. It is nice to be at Academy. You know, things aren't normal, but it's a start. Nice to be in New Orleans. So I'm a general ophthalmologist. I do cataract surgery, a lot of premium cataract surgery. I do diabetes care, glaucoma care, neuro-ophthalmology, and I see a variety of patients in that setting. I'm a solo practitioner. I just opened up my own solo practice about a year ago. I was part of a larger practice in Charlotte, and that's where we first got involved with ERG. And gosh, almost 10 years ago, and your device about 7 years ago. The first device we used was kind of an older generation device, not your company, but that was an improvement over what I had experienced in medical school. I like to tell the story of how I first learned about ERG. When I was in medical school, I did rabbit research, and ERG was very neat, very interesting, but it was very cumbersome, complicated, difficult. This technology, game changer. But it certainly got me interested in it because you run the test, you get that magical little number, and your device certainly makes things really easy. And so I use it on a ton of my patients.
Thanks, doctor. So you mentioned both glaucoma and diabetic retinopathy. Give a little more background on what you do there.
Yeah, so I use the test probably equally for retina and glaucoma. For retina, we use it for macular degeneration, epiretinal membranes, but also I have a big diabetic retinopathy patient population, and I'll talk about that. You know, I tell everybody that we're missing something in the old way of doing things. The old way is basically just an anatomical assessment of the patient where we examine the patient, that's anatomy. We do photos, that's anatomy. We do FA, anatomy, OCT, anatomy. But there's something missing that this device provides, and it's really the tip of the iceberg, because if you have two patients, for example, who have a hemorrhage near their fovea, a patient with diabetes, you run the test and they look the same, you can get very different results that are reproducible. And so it tells you there's something going on, again, at the cellular level, microvascular level, that we just can't see. And it's applicable to all sorts of diabetic conditions and other retinal disease. And then glaucoma, there's a ton of opportunity there for glaucoma. We run a slightly different test for glaucoma. And so it really helps us essentially, all things being equal, as a tiebreaker for patients if I'm not sure how to treat them, how to manage them. I'm sure we'll talk a little bit more about that. But yeah, I use it extensively for diabetes and glaucoma patients.
Okay. Yeah, studies have shown about a third of glaucoma patients are normal tension glaucoma. So how does this help you in assessing those patients?
Yeah, you know, that's always the challenge of glaucoma. We get a lot of referrals. I get a lot of referrals from optometrists in the community. Pressures are sort of borderline. The cup to disc is a little bit abnormal. Maybe the field's a little bit abnormal. You take in the whole picture. So this is another tool that helps us make the decision on if we're going to treat or if we're going to follow the patient, how aggressively we're going to follow the patient. And it really, you know, we've got visual field testing, which is subjective functional assessments, but we really don't have objective functional assessments until this technology came along. So I've really incorporated in my practice, embraced it. It's fantastic.
Okay. And how has it changed the care, the way you deliver care?
Yeah, so I think there's lots of ways. It helps us identify who do we have to worry about. For example, that's this patients with the retinal hemorrhage, the same two patients. I run the test. The patient, the ERG is perfectly normal. I'll see him back in a year. If the test comes back abnormal, I'll see him back maybe 9 months, maybe 6 months. So it really sort of guides, first of all, how often do I see the patient for those diabetic patients? Because you really want to, we don't have time to see every diabetic patient constantly. So it really helps fine tune that. Who we want to refer out to retina. If somebody's on the fence, I'm not sure. I run the ERG if it's significantly abnormal. I'm like, yeah, I'm going to send them on to retina for treatment earlier. The key for diabetic retinopathy, for glaucoma, you want to detect disease as early as possible. And this technology certainly helps us do that because, again, anatomy sometimes it's not until there's significant damage before it shows up on exam, on photos, on OCT. And having this technology that can detect disease early, it's really a game changer for us.
And in your practice, how does it fit with the patient flow in your practice?
So that's the beauty of it. I talked about the ERG when I was a medical student 25 years ago. So if people have experience with ERG, they hear the word ERG and they think, oh my gosh, I can't do it. It is so easy. First of all, the device. Now I tell my patients the device looks similar to those thermostats we use to scan the forehead. It's literally about that size. It takes 2 minutes to run the test. So typically for new patients, I'll see a patient, I'll examine them. Right then and there, I'll pop out of the room, tell my technicians, can we get an ERG retina on this patient? And I'll either go see another patient or I'll finish the note on my last patient. Within 5 minutes, that test is done, imported to our EMR, and I can interpret it. It's really easy. So it's really not disruptive to patient flow. Patients don't mind it. It's really easy.
And how do your techs feel about this device?
Yeah, so very, very easy learning curve. It takes about 2 minutes to teach the test. The key is you want to place the electrodes properly, but even that, it's very forgiving, this test. But once the technician learns that, and we have students who rotate through our practice, and we're very hands-on with our students, and we let the students run the test, and after 1 or 2 tests, they get it. They don't have any trouble running it.
And in your practice, I mean, when you're looking at patients on a given day or a week, what percentage of patients do you think you'd utilize this device on?
Yeah, so it's quite a lot, Jim. So first of all, it's my cataract practice. So I do it just in premium cataract surgery on. If they have any retinal abnormality, I will run the test for many reasons. One, it keeps you out of trouble. If you see a patient with, for example, a little bit of diabetic retinopathy, and the patient's interested in a multifocal lens, and maybe I'm a little hesitant to do it, I run the ERG. If it's abnormal, I'll avoid the multifocal. But also, I found it's more the other way around, actually. I found that I was maybe a little bit too conservative in offering premium cataract surgery to patients with a little bit of retinal pathology. And running this test, if it's a normal ERG, it really gives me confidence to really recommend. We might adjust it a little bit, but recommend that premium surgery.
And for someone in their practice who's heard about it or maybe never heard about it before and is reluctant to implement an ERG in their practice, what words would you have for someone like that who's considering it?
Go for it. Go for it. I think the science is there. It's easy to use. It's reimbursable by insurance. And like I said, we're just scratching the tip of the iceberg here. It's got so much potential, and I really believe in. We have a role as physicians in sort of recognizing innovation and technology that can really help lead our profession, medicine, but especially ophthalmology. I mean, when you think about it, in the electrophysiology realm, ophthalmology is really behind the times. I mean, cardiologists have been doing this for 100 years. Neurologists have been doing it. It's really time that we catch up. And I encourage everyone, we need to invest in this technology. Otherwise, we're just going to continue to get left behind.
One final question. How does it feel to be back at an academy meeting?
Yeah, it's great. It's nice to see people, see old friends, and it's nice to be in New Orleans. And yeah, it's very nice.
Well, Dr. Calabari, we thank you very much for joining us today. We appreciate you sharing your perspective.
Absolutely.
And thank everyone out there for listening to this live and also through our YouTube channels. Thank you very, very much.
Thank you. supposed to be up.
Yeah, that's true.